All right, good evening, everybody, and welcome to another Wu University event. My name is Dr. Stephanie Wu, and I am the host of Wu University and the founder of Wu University. And this is a really exciting event because we have record-breaking registrations. We have 1,300 people that have registered for this exciting event. So we know it's going to be an amazing time tonight. Thank you all for your support. And we're really excited about this event. And it is my pleasure to introduce a good friend of mine, Dr. Stephen Sorkin. Dr. Sorkin earned his Doctor of Optometry degree from the State University of New York College of Optometry. He has received multiple clinical honors and has participated in many contact lens related studies. He lectures extensively throughout the country and internationally on contact lenses, dry eyes, ocular allergies, ocular therapeutics, and corneal disease. He currently serves as the president of the Essex County Optometric Society and is a member of the board of directors of the New Jersey Society of Optometric Physicians. He's also a fellow of the Scleral Lens Society. That's how I actually first met Dr. Sorkin. And he was named New Jersey Optometrist of the Year in 2018. Well, Steve, it is so exciting to have you on Wu University, and we're so excited to hear from you tonight. Can't wait to hear your presentation.
Thanks so much, Stephanie. It's a pleasure and an honor. And I'm just looking at all the other people that have been lecturing at Wu University. I'm honored to be in the same group with a lot of these people that I respect tremendously. So just a brief financial disclosure, I'm not going to be talking about anything tonight that is anything applicable to any of these companies. Whenever I start my lectures, obviously we're talking about oral pharmaceuticals. I always like to start off my lectures with a cartoon. So we all have those patients that bring in a handout and they want to go over everything with you and they get prescribed the medication. All right, so before you prescribe oral medications, in fact, anytime you prescribe any medication, you definitely want to have a handle of, your most important medications that you use on a regular basis. These are the ones that you don't really need to look up any dosages or side effect profile or contraindications, but there are definitely a lot of resources that you can look at. Hippocrates is a great app that you can use. I use it all the time. You can either download it onto your phone or you could have it on your desktop. GoodRx is used as a website, but also has a great resource. We'll talk about looking up medication cost if you can try to advocate for your patients so that they can get their medication at a lower cost. If you want to look at a book, Frauenfeld, there's a great reference there. I definitely want to emphasize to utilize pharmacists. I think they're very helpful to ask questions regarding certain things that you may have, things that are not run of the mill. Also, there's another website called RX List as well. This is the old PDR, so I threw this in because hopefully none of you guys are still using this. It was used years ago before computers, where you just look up the monograph of every medication. Unfortunately, it really doesn't have anything applicable to what we need. I still get the postcard in the mail every year if they want to renew this. The only thing really you can use this for right now is kind of as a door stopper. So hopefully you guys have moved on from using the PDR. So let's just start a little bit talking about pregnancy categories, because obviously if we're going to prescribe medications to pregnant women, we need to know if the medication is going to be safe to use. So classically, this was the five different classifications that we used: A, B, C, D, and X. A, safe for use in pregnancy. There's really nothing out there that's category A other than possibly water. B is the ones that we're kind of comfortable with, and that's the medications I'll try to stress tonight during the lecture, where animal studies have not demonstrated any fetal risk. C is where just about all the medications that we use are in that classification. So they really don't have any adequate human studies. So we basically just have to use our professional judgment if we're going to use those. And D, the big one that we know is the tetracycline family that does have an evidence of human fetal risk. So obviously it's contraindicated in a pregnant patient. And X is, these are non-available medications to us. There is a new classification system that was started about 4 or 5 years ago, and it only is applicable to newer medications that have come out after 2015. So really in eye care, there's really not too many medications that are in this classification, and really no oral medications we're going to be labeled like this, but it does actually break things down to, pregnancy, lactation, and 8.3, which is the females and males of reproductive potential. So if you do see any new medications out there, they may have this label, and switching over from the A, B, C, D, and X. And during the lecture, I'll point out which of these medications are in which class, and I'll try to highlight that for you. So before you prescribe, really the main things you want to ask is, are they allergic to any medications? That's important, and we'll talk a little bit about how that is asked to a patient and how their history plays a role in deciding what medication you want to prescribe. What medications they're currently taking, and that can be very challenging. Are they taking prescription medications? A lot of patients don't think that over-the-counter medicines are actually can affect the body and the eyes, even herbal supplements as well. So you have to ask them not only, are you taking prescription medications, but what are you taking over the counter? And that includes supplements, that includes vitamins. So you definitely want to ask them those type of questions, because that could possibly affect your decision making and also how you're treating the patient. Systemic conditions, we'll talk about that. Obviously, the main ones that everybody knows about. Is their immune system healthy? Do you have a patient that's on chemotherapy or other types of treatment that may affect your treatment thought process? And anything from an oral medication basis, of course, you need to assess their liver and kidney status, and we'll talk about that specifically when we're dealing with medications such as antibiotics and also even the antiviral medications. Also take into account the patient's age. So if the two rules of thumb, if they're a child or elderly, you may have to adjust the dosage or the strength of the medication that you're prescribing. This is where either your pharmacist would be helpful or corresponding with their medical doctor, either their primary care doctor, or pediatrician, or could be an oncologist, depending on what's going on. Polypharmacy is a big issue, especially with the elderly patients, where they're going to different doctors and they may forget that one doctor has given them one medication. And we run into this a lot, obviously, with eye drops, where a patient may bounce around and get different drops from different doctors, whether it be glaucoma medication or antibiotics or steroid drops. And you want to make sure that you have every single medication that they are taking. Some EHRs will allow you to access all of their pharmacy records, which is helpful, and you can even check on them and see if they have any undisclosed conditions such as diabetes or hypertension. Insurance status, especially nowadays, how much our medication is going to cost. Are patients going to be able to access the medication that you want to prescribe for them? If you want to go through the process of prescribing a brand name, if you feel that that's important versus going with a generic. And if they're on birth control as well is another thing you want to ask a patient. This is just a meme that I threw in. You claim you have medical history, and then of course they throw in all these things, the medications that they're taking. So this again is polypharmacy. We always get scared about those patients that come in to the office with a bag of eyeglasses, but they can also come into the office with a bag of medications. And again, if they're not having their providers in contact with each other, they can be having duplicate medications or medications that shouldn't be taken together. So this is something that you have to be aware of. And some elderly patients, unfortunately, are a little less aware of what medications they're taking. They get a little confused. And we all, of course, have come across that along the way. Compliance, of course, is very important, making sure that patients are taking the medications that are prescribed at the right time, the right day, the right dosage, making sure they're not missing doses. And we know that, of course, with a lot of our chronic diseases, such as glaucoma. So definitely try to assess the best you can what their compliance is. Again, some EHR prescribing modules do allow you to see how often or when patients have actually refilled their medication. So we could even go in and see if they have a dry eye prescription, see if they're keeping up with their dosages and they're filling their prescription as needed. Again, they could be filling the prescription, but that doesn't mean obviously that they're compliant and taking it when we want them to. Again, the cost aspect, nowadays with these high deductible plans that all of our patients seem to have, and the Medicare donut hole. So sometimes it's a problem, especially at the beginning of the year when the patients have not met their deductible. So I have a lot of patients that'll call in, the middle of December and get another 3 months supply of certain medications. So it's under the current year deductible, which they've met, rather than waiting till the early part of the next year. So, we have patients do that obviously with contact lenses as well with their HSA plan. So you definitely want to be cognizant of, cost, make sure that if there is a medication that has a coupon, try to assess anything that you can to try to assist the patients in getting the medication that you do want. So again, another cartoon, which is, very, very common, where patients are just very frustrated about access to medications and cost of medications as well. So, again, review their medical history. We talked a little bit about using EHR, review their prescription and over-the-counter medications. Sometimes I'll go through a process of even talking about things like omega-3 fish oil, and we go through the whole thing about it, and then they go, oh yeah, I take fish oil, and they didn't tell you at the beginning of the exam when you're asking them the medication history. One of the tricky things to always assess is a true allergy versus side effects, and we'll talk about things like penicillins being very important in trying to assess whether or not you can prescribe a medication for a patient. Again, pregnancy may change some of your decision process on prescribing certain medications, and nursing women as well. And like I said, children and elderly, you may have to titrate the dose of those medications, especially since they may be on other medications as well at the same time. Hopefully none of you guys are still using these archaic, health history forms, which take, 3 hours to fill out, and then you wonder why your clinic day is running long. We really don't care if a patient had bunion surgery in 1989. You just try to get to the crux of what they're coming in for and the main type of medical history that you want to do. This is Wilford Brimley. So when you see this, you think it's candy time, and let's go get some Nestle Crunch or a 32-ounce Big Gulp. Those patients come into the office and they say, no, I don't have diabetes. I'm just taking 1,000 milligrams of metformin per day. So a lot of patients will not fully disclose what medical conditions they have. And in fact, sometimes they don't think that they have a medical condition because they're taking medication for it. We've all been through that. So if they're pregnant or trying, you definitely want to ask them, particularly with the oral medications that we'll talk about, even topical medication, of course, it's applicable. So I always like to call the OBGYN just to cover myself. Most of the time when they hear it's an eye doctor calling, they're just gonna say, yeah, it's fine, don't worry about it. But I would recommend, from a practice management standpoint, medical legal standpoint, saying I spoke to Dr. X, the OBGYN patient was okay to take this medication. So good practice management recommendation for you guys. So these are the medications that we'll sort of touch on tonight. These are the main ones that I prescribe, and the good news is just these are all medications that are safe to use in pregnancy. So we'll talk about some of the penicillins, the macrolides, and the antiviral medications, and some of the pain medications that we prescribe are also category B. So what would be some of the causes of failure for therapy? These are the 6 big ones that we'll hit on. Of course, inaccurate diagnosis. You want to make sure that you're diagnosing the patient properly. So obviously, if you don't have the correct diagnosis, you're probably going to be prescribing the wrong medication, such as prescribing, Tobradex for a dendrite. Inadequate dosing, typically a lower dosing that's necessary. We're very familiar with that, treating things like uveitis where we're not prescribing a high enough dose or a strong enough steroid drop. Resistant organisms, this comes into play, especially when we're dealing with antibiotics, and nowadays with a lot of the non-ocular treatments, so none of the systemic treatment, where primary care doctors are just prescribing a lot of antibiotics that are probably unnecessary. So that promotes resistance, or again, using the wrong antibiotic on a specific clinical condition. As we touched on before, non-compliance is a big issue as well. Patients, you give them medication and they don't take it correctly, or they stop it too soon. Toxicity going the other way, if you actually don't use it the right way, in the wrong way, they overuse it, like somebody using latanoprost 4 times a day rather than once a day. Allergy also plays a role both in severe anaphylaxis and also just allergy to certain medications as well. So let's just start. The first category I wanted to talk about is pain medications. So the two that I want to talk about are Tylenol #3 and Vicodin. So these are ones that, again, you can use them in pregnancy. Why would we use pain medications in eye care? And the thing that you really want to be aware of is that really we only want to use it for a short duration. If you're using pain medications more than 2 or 3 days or maximum of a week, then you're either misdiagnosing the patient, or the patient may be a drug seeker. Because again, for eye care, really we're just trying to get them over the first few days of any type of discomfort that they have. You could a case could be made for corneal abrasions or recurrent corneal erosions if they have a severe form, specifically trauma. We have used it sometimes in severe corneal ulcers, but I would say that the problem with using pain medications or oral pain medications like narcotics in an ulcer patient, and even a patient with, let's say, uveitis, is that you're masking the pain. And a lot of times when we're managing these patients, if they're coming back for corneal ulcers, we're seeing them pretty much every day. And if you're giving them pain medications, they may say that they're feeling better, but the ulcer may not be getting better. One of the ways that we determine how our treatment's going, other than obviously clinical examination, is asking them how they're feeling. Specifically with ulcers, if we're moving in the right direction in a day or two, the ulcer may not feel better, but they may not be looking better, I should say, clinically, but they may say that their eye feels a little bit better. And that makes you feel a little bit better that you're moving in the right direction. So you can mask that with pain medication. So I'd say for ulcers and things like uveitis, I think using pain medications is probably not the best approach, unless in extenuating circumstances. We do, however, use it in our post-surgical patients. Those of you who co-manage PKP patients, and specifically the surface ablations like PRK and PTK and collagen cross-linking, especially if you're doing epi-off, pain medication for a few days to let them ride out the first few days of not having an epithelium is probably a good idea. I remember a few years ago, I was in the office. It was a holiday weekend. I think it was Memorial Day weekend. I got a call like Sunday afternoon from a patient who had epi-off cross-linking on I think Thursday. And they called on Sunday, and I knew this guy was like a military guy, so he was a tough guy. He said, "I am in miserable pain." So I said, "All right, I'll come see you in the office. Maybe the bandage lens fell out. Let's take a look at you." The BCL was still in, but he still had this huge epi defect. And I said, "You know what? It's Memorial Day weekend. Let me give you some Vicodin for a few days to get you through." And he was very appreciative. I saw him, Tuesday or Wednesday, and he was doing much, much better. So you want to be humane. You don't want to keep pain medication from patients if needed, but you of course want to use it judiciously. But a lot of us on the call today, they may not have a DEA number or may not be comfortable prescribing narcotics. So most times in eye care, topical NSAIDs would work fine, and a BCL, let's say if it's a corneal abrasion or recurrent erosion, you don't need to go down the oral pain meds road. And again, if you don't have a DEA number, or if it's contraindicated, as we'll talk about, you can use over-the-counter NSAIDs. And a really good approach is to sort of switch off between ibuprofen and acetaminophen, assuming they don't have a NSAID allergy or don't have any liver disease. But this way you can sort of go back and forth between the ibuprofen and acetaminophen. And some of the studies have actually shown that it's almost as effective as using a narcotic pain reliever, obviously not having to worry about the other issues with narcotics, which we'll talk about. Okay. So with narcotics, we do get a lot of patients that'll say, "I have a codeine allergy," or that type of issue. And a lot of times the narcotic allergy is really because they just get nauseous, which you'll see with a lot of the oral medications. A lot of the quote unquote allergy is really just GI upset. And these medications can definitely cause that. Or I get sleepy. And of course, that's one of the side effects of narcotics. You want them to kind of go to sleep. So patient can equate that to a side effect or an allergy, where really it's just more of a an expected thing that happens with these medications. So anytime you're prescribing things, especially narcotics, you definitely want to make sure that you're diagnosing and treating the problem appropriately. Like in other words, if you're doing an erosion or abrasion, you're getting a BCL on there, getting an antibiotic coverage, cyclopleging the patient. These are important things that you want to do first, and then you can manage the associated pain if needed with narcotics. So some of the side effects of narcotics, nausea, vomiting, as we said, the GI stuff. It could also cause constipation. I think there's an ad that I keep on seeing on TV that has to do with narcotic constipation. I can't remember the name of the medication, but I keep on seeing it on TV. Dizziness and sedation, of course, you have to make sure that they're not going to be driving a motor vehicle while taking this medication. And the big one, of course, is addiction. Dr. Hanna had a great lecture last night on Wu University. I tuned into that. It was a great lecture on opioids, and you really need to be aware that that's out there. It's a big issue, and you really want to make sure that if you're prescribing this stuff, again, for eye care, we're only prescribing it for a couple of days. We're not going to prescribe it with refills and everything. So they do get it for a very limited time, but there are patients that are looking for this type of stuff. And I've had a few patients that have come in that kind of ask for it during the exam. And when the patient actually knows the dosage and the milligrams better than you do, then you kind of have to be careful and really take a look. I will tell you that in New Jersey, and I think in a lot of states, there's actually an opioid registration. So anytime any of these medications are prescribed, there's a list that you can go on. The pharmacist look at it. And you can kind of see what the patient's history is in this area. And if you see that they're sort of a seeker, then you can be very careful about prescribing medications for that type of medication for those patients. So Tylenol number 3, for those who don't know, number 3 means that it's 30 milligrams of codeine. There's a Tylenol number 4, which is 40 milligrams of codeine, and number 5, of course, is 50 milligrams of codeine. All of the Tylenol opioid medications have 300 milligrams of acetaminophen, which we'll talk about in a moment. So Tylenol number 3 is a category 3 controlled substance. So again, if you have a DEA number, certain states have certain restrictions or allowances for certain categories. Most states will be 3, 4, and 5. Some states do have 2, I believe. New Jersey, we're 3, 4, and 5. So that's the dosage, 1 to 2 tablets every 4 hours. These are the side effects of the opioids. So again, do not use alcohol when using opioids. So again, be careful with substance abuse risk or history if they have hypersensitivity. Be careful if they have any type of asthma or COPD, any type of lung disease. And again, the liver and kidney dysfunction is something you have to be cautious about. And just to let you know, the hydrocodone acetaminophen or the Tylenol number 3 products are the most frequently prescribed oral med in the United States. So that is crazy. This is just, again, a large corneal defect from an abrasion or recurrent erosion. And this is where you basically throw on and bandage contact lens and antibiotic. Don't forget to cycloplege them. And then if you feel for a narcotic for a couple of days, or manage them with Tylenol or Advil. Next one is Vicodin. This one was reclassified from 3 to 2 back in 2014. And in my state, New Jersey, we're not able to prescribe Schedule 2. So our state, and I know a lot of other states, had to have help on the AOA, and we had to go ahead and reclassify this medication in our formulary. So we're able to prescribe Vicodin even though it is Schedule 2. So these are the 3 different levels of Vicodin. The 5 milligrams is the regular Vicodin, and then they have the ES, which is the one that I usually prescribe, and the HP, which is obviously the high potency one, which is 10 milligrams. That one's usually out of our jurisdiction as far as the prescribing, and I think it's way too strong for what we need to do. So usually I prescribe either the Vicodin or the ES. So again, the same type of side effect profile. You have to watch out for all these medications as far as respiratory distress, so if they have COPD or asthma. And all the acetaminophen products, the maximum dosage is 4 grams per day. So I alluded to the 300 milligrams per dose. Originally, it used to be 500 milligrams was in the acetaminophen portion of these medications. They used to have 500 milligram acetaminophen tablets. They've cut that down to should be 325, but the manufacturer just decided 300 was the way to go. So anytime you're prescribing these medications, it'll be fixed at 300 milligrams per dose. And again, you have to be careful on how many you're giving per day, and also make sure that they're not taking any other type of acetaminophen product along with this. So again, the 4 grams per day. So, as far as a public health thing, acetaminophen is the leading cause of liver failure in the US. Ultram or Tramadol used to be a non-scheduled medication, so it's not a DEA scheduled medication, but it was reclassified as Schedule 4. So it is now a controlled substance, and you do need a DEA number to prescribe it. It is an opioid, but it's not quite as strong, and it's not quite as addicting as some of the ones that we just spoke about. This is the dosage. This is one of the ones that is a little unusual in the fact that we are saying this is a category C. So just about all the other medications during the talk tonight will be B, but I wanted to point out that it is category C. So again, respiratory depression is a side effect of the Ultram. I'm not sure how many of you have prescribed the Ultram or Tramadol. Okay, so just getting back to Tylenol, if someone does have an allergy to aspirin, or if they have a bleeding disorder or they're post-surgical, instead of giving them an NSAID, you can give them Acetaminophen. Obviously, there's no anti-inflammatory property with Acetaminophen. It's antipyretic and pain reliever as well, but it's not anti-inflammatory. So children, again, there's Rey syndrome with aspirin, so you have to give this to children. And also it's category B. So if they're pregnant or nursing, Tylenol or Acetaminophen is the safer way to go. Okay, we're moving along. Okay. All right, so the main part of the lecture now will be on anti-infectives. I'm not going to really talk about antifungals. I threw it in there. I don't know how many of you prescribe, oral antifungals, but we're definitely going to talk a lot about antibiotics and antivirals. I always have to throw in an organic chemistry slide. Don't worry, we're not going to go over this stuff. But I did want to say that it's important when you're prescribing oral antibiotics or any antibiotics for that matter, that you understand sort of the functionality and the mechanism of action of these medications, because some of them are going to be duplicates. And if you're having a difficulty with a specific type of antibiotic and you're not going to want to prescribe the same type of antibiotic mechanism, you want to prescribe something different. So we know that some of them do inhibit cell wall synthesis, disrupt cell membrane, DNA synthesis like the fluoroquinolones, and also to know if they're bacteriostatic or bactericidal, because that goes back to, are you prescribing the right medication for the right condition? So just make sure that you know that certain medications, like we're using doxycycline more as a bacteriostatic rather than a cidal medication. Okay, why do we prescribe oral antibiotics in eye care? And it's really for lid things. The dacryos, the cystitis and the dacryoadenitis. We'll talk about preseptal cellulitis, rosacea, which specifically will deal with the tetracyclines, also hordeola and chalasia, chlamydia. I hope none of you guys out there have a chlamydia center of excellence, but chlamydia is in our purview, and orbital blowout fractures if you're seeing any patients with trauma. So it always comes down to, are antibiotics truly needed? We go through that decision process all the time with topical medications. The problem, just like the primary care docs or the urgent care docs have, is that somebody comes in with an infection and you almost feel like you're obligated to give them an antibiotic or give them something because they paid this copay to come in. And a lot of times, as we know, especially viral conjunctivitis, we don't need to give an antibiotic. It's not necessary. But sometimes patients will kind of expect and demand it. So you definitely want to be able to prescribe it only when needed, because we don't want to obviously incorrectly treat somebody, give them unnecessary medication, and that can cause resistance. Also, what organism are you treating? That goes back to your history. What actually you're seeing? What exactly happened? Did they get a bug bite? Did they get a scratch? Did they get something in their eye? How old are they? Again, if it's a pediatric patient, you think it's Haemophilus, or is it strep or staph? The contact lens wearer, is it things like, the acanthamoeba or something like that. So you definitely want to know, or have an idea what organism you're treating. Of course, you can culture them if needed, but most of the time, of course, we're always doing empirical. History of allergy, drug reaction, do they have a problem with the specific medication, this class of medication? And of course, especially if you're doing oral medications, definitely know what their kidney and liver status are. The generics, we always factor into, cost and availability. Just about all the medications I'm going to talk about tonight are generic. So, shouldn't have to worrying about too much about having a brand name. There's really been no, new antibiotics, oral antibiotics out in a very long time. So these medications have been around for a while, and they typically now are available as a generic. And you definitely want to make sure that even if they clear up and they feel better, that they should always take that full course of therapy, because we don't want to build up resistance. So even if they feel better in 2 or 3 days, which we hope they will, sometimes that's the case, then just tell them to continue to complete the process of the antibiotics, whether it be 7 days or 10 days in most cases. These are just the 6 main classes of antibiotics. I kind of put it in order of what the amount that I prescribe. Definitely the penicillin, like Augmentin, is my number one going down the line, and we'll talk about all these different classes as we go through the lecture and kind of see why the sulfas and the fluoroquinolones are at the bottom of the pack there. Let's start with Augmentin, which is probably my number one prescribed antibiotic. I'll tell you why. We talked about what organisms, so it's really factoring in mostly gram-positive and some gram-negative. It is amoxicillin, so it's a penicillin. Amoxicillin doesn't really do great because there's so much resistance to amoxicillin. So what they did is they put this clavulanic acid in there, which is actually not an antibiotic itself, but it just potentiates the amoxicillin, so it allows it to get by some of the resistance that's found in a lot of these bacterial organisms. So with the clavulanic part, it's standard at 125 milligrams per dose. So you don't need to fix that or change that at all. The only thing you're changing is obviously the amoxicillin milligrams. It is category B, so it's safe for use in kids and also in pregnant women. The dosage is typically 500 or 875. A lot of times I'll prescribe 500 3 times a day. If they're lighter in weight, then I may do 500 BID. And then if you want to just the heavier, stronger gun is 875 BID. So again, 125 is standard. There's a chewable, there's a liquid. So these are mostly for skin and soft tissue infections like staph, strep, and Haemophilus. These are gram-positive. Good for human and animal bites. Going just caution as far as drug interactions, just some of the gout medications like allopurinol. So this is a presentation of a Dacryocystitis. So that's in the lacrimal duct area. This is obviously a huge, whopping swollen eyelid, and of course your topical medications are not going to cover this. So you're going to definitely need an oral antibiotic. You can give them, a topical as well to cover the lid itself, but for internal purposes, you're going to definitely need an antibiotic. So for this, I would prescribe, amoxicillin, Augmentin 500 TID or 875 BID for 10 days. Obviously, hot compresses, and see them back. Hopefully, that'll resolve. That's called Dacryocystitis. Let's talk a little bit about allergic reactions. So allergic reactions in antibiotics are fairly common. We see this here and there. A hypersensitivity reaction, which is mediated by the IgE. Typically, it's a skin-related reaction early on. You get a skin rash, hives, or itching, and patients will tell you that they do get that while they take these medications. Obviously, if it gets more concerning when they start having breathing difficulty or wheezing, and then they get swelling of lips, face, or throat. That's more of a medical emergency. That's why I have that little ambulance there. So that's when you want to, definitely call, ambulance and emergency care right away. So the thought is that 10 to 15% of the population is allergic to penicillin. So if they do have a true allergy, like one of these things where you get a rash or breathing difficulty, obviously in no case would you want to prescribe a penicillin. Anything like Augmentin or amoxicillin, any of those type of medications, not a good idea. So whenever we try to factor in the allergy part, and this is difficult because a lot of patients, especially the older generation, all think that they're allergic to penicillin. First of all, way back when, that was almost the only antibiotic that was available, and their mother or father told them they were allergic, when really what happened is they got a stomach upset. It's not a true allergy. So it's sometimes hard because they probably had it as a kid and they were told that they shouldn't be taking it. So sometimes you just don't know, and if you have any doubts at all, then obviously don't prescribe it. So there is allergy testing now for penicillin, and my wife is one of them where she thought she had penicillin allergy, and a few years ago we took her to the allergist and they did skin testing on her, and she's not allergic to penicillin. So it's something that if you feel it's important and you feel like you need to do, and obviously it's not an urgent thing you have to do, but you can tell a patient they can go see an allergist and then get worked up for penicillin allergy. Let's move on to the cephalosporins. So we just went through the penicillins. So cephalosporins are kind of in the same, cousins of the penicillin. So there is some cross-sensitivity to those. There are many different generations of cephalosporins. I think there are up to 5 or 6 generations now. But mostly we'll stay within the first 1 or 2 generations what we'll prescribe for. The first generation is, again, it's good for soft tissue infections. This is where you have the gram-positive coverage for staph and strep. the way it works with the cephalosporins, as we go up in the generation, so first generation is mostly gram-positive. As you go through 1, 2, 3, 4, 5, that becomes better for gram-negative. So the first generation more gram-positive, and then later on more gram-negative. So the main one that we prescribe for the cephalosporins for the first generation is something called Keflex, which is typical dosage. Again, pretty similar to what we talked about the amoxicillin. It's 500 TID or 750 BID. It's cheap and generic, as just about all these are by now. If you do have an orbital blowout fracture, Keflex is a really good option for that patient. This one also is a category B. And as I said, there's a 5 to 10% cross-sensitivity between penicillin and the cephalosporin. So if they do have a penicillin allergy, you kind of have to tread lightly on that. I'll talk about that in the next slide or two. And just like any antibiotic, you definitely want to take caution if they do any type of renal dysfunction. So if they do have that type of issue, you may want to touch base either with their primary care doctor or the nephrologist before you prescribe these medications from an oral standpoint. So this is a preseptal cellulitis. This is something that is a little more severe than just hordeolum. So in this case, again, topical medications will not dent this. So you're going to definitely need to look to do oral medications for this patient. So let's talk about preseptal a little bit. Just going back to to definitions, it's a infection or inflammation that is anterior to the orbital septum and it's limited to the superficial parietal tissue. So that distinguishes itself obviously from true orbital cellulitis, which basically breaches the eye and gets into the to the orbit. So you have to be very careful on determining those things. Typically, a patient will say that they had an internal hordeolum, or trauma, or a sinus infection, and then it definitely turns more into a preseptal cellulitis. So they will get the swelling, redness, and pain. They can get a low-grade fever. I know we were always taught that if they had a fever, it was always orbital cellulitis. But if they had a low-grade fever, like 99, 100, that could typically be a preseptal. And I think now with COVID, I don't know, if any of your offices is still checking temperatures, but everybody should probably have a thermometer in their office now. So, if you want to check that just to see what kind of fever, if they do have or not. But there is no restriction on EOM. So that's sort of the other distinguishing factor between preseptal and true orbital cellulitis. And of course, if it's orbital cellulitis, they're going to be out of your office and they're going to the ER to get IV antibiotics. So typically we prescribe, can prescribe a cephalosporin, typically Keflex or Ciclor. But if they do have a MRSA possibility, then you can consider Bactrim or Septra, which we'll talk about in a few slides down. Of course, if they don't have a sulfa allergy, but Keflex, 500 TID or 875 BID would be perfectly appropriate for preseptal. Those patients you probably want to watch a little more carefully, see them back in a couple of days, make sure that it's not getting worse. And again, if it is getting worse, then I'd send them either to an oculoplastics doc that or send them to the ER and get them evaluated there. They may need to get scanned. So Ciclor is a second generation cephalosporin, so a little less resistance, a little bit more gram-negative coverage than the first generation. And these are the dosages of these medications are 250, 500 TID. And then there's an extended release, which is 375 to 500. And this, again, in the cephalosporin category, is cephalosporins are category B. Okay. So the side effects, we talked about the penicillin cross-sensitivity. As you go toward the higher generation cephalosporins, the penicillin risk becomes less. We'll talk about that in a moment. All the antibiotics, you have to worry about GI upset. Pseudomembranous colitis is C. diff. These are things that unfortunately happen sometimes with antibiotics. So case be made, to think about doing probiotics or having them take yogurt whenever they take an oral antibiotic, and a lot of them they should be taking with food. Vitamin K disorder, bleeding is an issue with the cephalosporins, and like I said before, renal impairment is a caution with prescribing these medications. So what if your patient is allergic to penicillin? What can you prescribe? So we talked about the cross-sensitivity with penicillin and cephalosporin. However, doing some research, the American Academy of Pediatrics came out a couple of years ago that now you can do, as I said, third generation or above, if they don't have any true cephalosporin allergies. In other words, if they're allergic, they said, to Keflex or to Ciclor, or severe atopic, atopic conditions. So, and a severe allergic reaction. So if they just have a very mild penicillin allergy, perhaps, then you can try to use one of these higher generation cephalosporins. To be honest with you, I've never done it. If I hear penicillin allergy, then I try to stay away from this category completely if I can. There are some options. They're not the most ideal in some ways, but you can definitely prescribe the macrolides, which we'll talk about in depth in a little bit, the azithromycin, the Z-Pak, erythromycin, which is the first generation, or clarithromycin, which is the Biaxin. You could also prescribe fluoroquinolones. That's taught at the end of the lecture. We'll talk about the pros and cons of that. And the tetracyclines, of course, that is category D. So again, pregnant patients and kids cannot take the tetracyclines. And usually the tetracyclines are more for inflammation in our case rather than anti-infective. There's an issue of the effectiveness of those. But if you don't have many options, that's kind of what you have to go with. Or you can even consult with an infectious disease doc if you have to. Let's move on to the sulfa drugs, which really in eye care is really limited use, really if you're concerned about MRSA or community-based infection. And the reason why I am very hesitant about prescribing sulfa, and I probably haven't prescribed it in about 5 years, is because of this Stevens-Johnson syndrome. Those of you who have not seen a patient with Stevens-Johnson syndrome, it's really heartbreaking because these are patients that have taken medication for other reasons, and then they develop the severe toxic reaction, something else called TEN, which is associated with Stevens-Johnson, where basically their mucous membranes just get devastated. It's a severe allergic reaction. It's really heartbreaking. And I've seen many kids that have taken antibiotics and had severe reactions, and it devastates the body. But also can really affect the cornea. It causes scarring, neovascularization, some blepharon. So I'm very, very cautious about prescribing sulfa drugs unless I really have to. Again, just for things like MRSA, if there's really nothing else to prescribe. You also have to worry if they have a sulfa allergy, which there is a fair amount of patients that do have it. So just be cautious. I know there are a lot of docs out there that prescribe Bactrim a lot. I know a lot of primary care doctors will prescribe it for UTIs. So just be cautious with sulfa. I don't want to scare you for prescribing it, but it's not my favorite drug to prescribe. So these are the Bactrim or the sister medication, which is called Septra. The main medications are 80 milligrams trimethoprim with 400 milligrams of sulfamethoxazole, 2 tablets every 12 hours. And then there's the DS or double strength, where basically you can see the 80 goes to 160 and the 400 goes to 800, which is 1 tablet every 12 hours. So it's basically half the dose of the regular strength. So the picture on the right there, I'm sure Stephanie is excited because that's a wine bottle. And those of you who don't know, Stephanie is a wine aficionado. So just to show you that some patients get confused between sulfites and sulfates versus sulfur, which is sulfur we know is on the periodic table. So sulfa is different than those things. So there are patients that just can't drink wine because they have a sulfite or sulfate allergy, but they can take sulfa. We talked about Stevens-Johnson being a devastating side effect of this class of medication. And to be honest with you, any medication can cause it. I have a bunch of patients, unfortunately, that have taken anti-seizure medicines like Depakote and things, and they've also had Stevens-Johnson. So it's not just sulfa allergies, I should be clear, but the sulfa medications are known to cause that in greater amount. Also, don't forget about the glaucoma version that we see for sulfa, which is the Diamox. I don't even know if Neptazane is available anymore. That was available a while ago. I'm not sure if I've even seen that in a long time. But Diamox we use obviously for glaucoma to lower intraocular pressure and angle closure. We use it for patients that are post corneal transplant surgery. So Diamox is used. So if they do have a sulfa allergy, then that's obviously contraindicated as well. All right, let's move on to the macrolides, which are bacteriostatic. So that's the mechanism of action is that ribosome synthesis. Very much be cautious of liver disease with these patients. Macrolides are geared more for the gram-positive organisms, and this one is category B. So these are some of the medications that are that you have to worry about with interactions. Digoxin's an old heart medication, Coumadin, of course, a blood thinner, even Lipitor, and Theophilin's an old asthma medication, not used much anymore. But there's your Dilantin, Tegretol, and Depakote, which are your anti-seizure medications. So Zithromax, and this is obviously the best-selling antibiotic in the U.S. Probably everybody on this call has taken a Z-Pak at one time or not another. It is a second-generation macrolide. The first generation is Azithromycin, which is taking 4 horse pills a day. Very much more side effect profile with GI stuff. So the Zithromax is definitely much more preferred nowadays, especially with the dosing profile, which we'll talk about. It is okay to use in pregnancy and with children because it's category B. We talked about the GI effects. And again, if you see patients, unfortunately, with chlamydia, it's the drug of choice for chlamydial conjunctivitis. And like I said, it's a very popular antibiotic. So the main one that we use is the Z-Pak, which is great because it comes in this little box. You don't even need to know. We talked earlier about knowing dosages and milligrams. This one is basically just Z-Pak. Use it directed for 5 days, and that's it. Comes prepackaged with 6 pills. So the first day is 500 milligrams times 2. So it's a loading dose, and then you use 1 pill for day 2 to 5. The nice thing about a Z-Pak is that it stays in the body for a few more days afterwards, usually 5 or 6 more days. So that's why you only need to use it for 5 days. It stays in the system for a long period of time. They're also a tri-pack where you're just narrowing it down now to 3 days. You do 500 milligrams once a day times 3 days. And then if you decide to do the chlamydia treatment, you basically do 2 500 tablets just at once. So it's good for preseptal, like soft tissue infections, any of these antibiotics, and even azithromycin, because of the overuse of it, of the medication, both by primary care doctors, urgent care docs for the URIs. And again, like I said, if somebody comes in with an ear infection, and they'll give them a Z-Pak or a sore throat just because they want to give them something to go home with. And this is an older stat, but 55 million prescriptions for azithromycin were prescribed back in 2012. So important, this is one of the most important slides of the lecture, is that you have to be very cautious about heart arrhythmias with Z-Pak. We'll talk about the fluoroquinolones at the end, but this medication can cause a prolonged, it's called QT time. And basically what will happen is that can cause heart arrhythmias, which can unfortunately be fatal. So I put that in red, use it with caution in cardiac patients. And my practice management recommendation to you guys, whenever I prescribe this medication, I'll ask them, have you ever taken a Z-Pak before? Have you ever had a problem with it? And do you have any cardiac issues? And if they say yes, then they may want to call their cardiologist or their primary care doctor to find out what exactly is going on. Because I'll write in the chart patient's nice cardiac history when they take that medication. So just be careful when you prescribe it. Okay. We'll spend a little bit of time on the tetracyclines. And I think when, for anybody who treats ocular surface disease or dry eye or MGD, this is obviously one of the most important medications that we have. I probably prescribe, Doxy probably more than any other oral antibiotic that we have. So it alters protein synthesis. Again, it's geared more for gram-positive. Secondarily, if you don't want to use a Z-Pak, you can prescribe this for chlamydia or Lyme disease. Just like anything else, increased resistance, you have to be careful that, tetracycline, especially since we're using them in a subclinical dose, that we won't be using them as an anti-infective. And a lot of times using them for many months, the resistant organisms do show up. Dermatology, of course, uses it for years for our patients with acne. So just be aware that there could be resistance. And fortunately for us, we're not, again, prescribing it for antibacterial properties, but these patients could be on it for a long period of time. So the way that it works for us, for MGD, is that it alters the sebum content, and it's anti-collagenase MMP9, which we'll talk about in a little bit. So use with caution with Coumadin. So if they're on blood thinners, just use caution. All right, so let's talk a little bit about, because I'm a cornea doc, recurrent corneal erosions. Let's just go down sort of the punch list of how we treat recurrent corneal erosions. I had to get at least a couple of cornea things in here. So one of the ways you can treat recurrent corneal erosions, obviously you can manage them with BCLs. We talked about that before, cycloplegia. use antibiotic drops. But one of the ways you can try to mediate recurrent corneal erosions is using oral doxy, let's say on a 50 milligram BID dosage for 1 month. Then I usually cut them down to 50 milligrams for once a day for the second month. And you can use any type of topical steroid like FML, Lotamax, any of those type of Flarex, any of those steroid drops on a QID or TID basis for about 4 to 8 weeks. So this is basically an anti-inflammatory. We find that patients with recurrent corneal erosions have a lot of MMP9, inflammation on the surface of their eye. So you definitely want to treat them aggressively for dry eye, especially if they have MGD. The doxy will, kind of do 2 things for them. It'll modulate the sebum in the glands and also reduce inflammation on the surface. And this does have a very high success rate where they, can minimize their recurrent corneal erosion, recurrences. I like to use fresh coat drops. You guys may know fresh coat drops. I always call that Miro Light. So the drops during the day, which are definitely more gentle to the eye than the Miro drops. And then they can use Miro ointment at bedtime. And then just for completeness, you can do debridement, you can do anterior stromal puncture, you can refer to a corneal surgeon to do PTK, or you can do diamond burr polishing. Obviously nowadays, amniotic membranes are a big thing. I'm not going to go into dry versus cryopreserved at this point, but amniotic membranes. Also, don't forget about using your topical medications like Regenerize, which is sort of a liquid amniotic membrane, or autologous serum drops. So there are many ways to treat recurrent corneal erosions. If any of you are interested, I have a whole lecture just on recurrent corneal erosions that we can give, and that there's so many different ways to treat it. There's no right one way to do it, but there are many ways to try to get this to resolve. So that's recurrent corneal erosions. But again, just to emphasize, the doxy with topical steroids is a great way to do it as a non-surgical. There's something obviously we can do in our office. So there are 3 different classes, the tetracyclines. Just like we talked about the macrolides, there are 3 different categories. The tetracycline is kind of like the erythromycin. It's the old one, high dosage. You have to use it 4 times a day. So it's really not used very often anymore. We kind of stick to the doxy and the minocycline. Minocycline I don't use quite as much because it crosses the blood-brain barrier a little bit more, higher risk profile for things. Doxy is kind of where we want to be. Sometimes there has been some shortages with doxy, and I have prescribed minocycline if needed. So this is the category D that we have to watch and be concerned about. Can't use in pregnant women or nursing patients. And I always, they always tell you under age 8. I usually try to err on the side of even up to age 12. I try not, because that medication can bond to calcium in the body and the bones and the teeth. So it can cause some severe side effects. So I try to err on the side of caution. Watch out for Coumadin, watch out for digoxin when prescribing the tetracyclines. So tetracycline, like I said, is the big horse pills, QID dosage, very strong, definitely has a much higher side effect profile. You have to be much more limited in what you can prescribe or how you can prescribe it. You have to take it on an empty stomach. You can't use dairy products or antacids. A much higher side effect profile with pseudotumor cerebri, which is now called IIH, idiopathic intracranial hypertension, which actually really shouldn't be called IIH because it's not idiopathic. We kind of know what causes it. It's caused by the tetracycline. Much higher profile of the photosensitivity, GI upset, and vestibular problems just because it's a much stronger medication. So we typically will prescribe it, less likely than the doxy. So those of you who know me in person, that I'm a big Seinfeld fan, so I have to throw Kramer in there. And Kramer, took doxy, and he didn't. But Kramer looks like he took doxy, and he, stayed outside and got sunburned. So just remember that depending on what part of the country you're in or what time of the year it is, that these medications can definitely cause sunburn, photosensitivity. So they should definitely cover up, wear a hat, wear a long sleeve shirt, use suntan lotion while they're taking this medication. So let's talk about doxy itself. A lot of uses for us in eye care, acne rosacea or ocular rosacea, posterior blepharitis or meibomianitis. Again, it works on the sebum. Chalazion management, not for acute infections. So chalazion are basically just walled off meibomian glands that have inflammatory debris in there that gets walled off. So doxy, we're using it more as, again, an anti-inflammatory. Lyme disease and chlamydia, we talked about that. We talked about the recurrent corneal erosions. I just wanted to point out again, being in a cornea practice, we do use Doxy a lot for our corneal ulcer patients because it does reduce MMP9. So if we have someone with a severe ulcer, we'll use it to prevent perforation. So we'll use it as an oral medication, along with obviously fortifying antibiotics and any other things that you need to prescribe. So it has anti-collagenase activity, so it prevents the cornea from perforating. Okay, so Doxy usually once a day or twice a day. This you can take with food. Just be careful about antacids about an hour or two before and after. You can take it with dairy. The photosensitivity is still a risk. And the birth control thing I should probably take out of the slide. Most of the studies now don't really show that there's really any impact on birth control. But it's still controversial still at this point. And one key that I would say with Doxy, one of the main reasons our patients don't like taking it, if they take a pill right before bedtime, then it can irritate their throat. So make sure you tell them to take their last dose at least 2 hours before lying down to go to bed. So it causes esophageal irritation. Very, very high amount or very diverse dosing, availability, different formulations. So let's kind of talk about that a little bit. It comes in 20, 50, or 100 capsule or tablets. I don't know if you guys, when I call up Doxy on my EMR, ERX thing, there's like 1,000 different choices. And it's like, which one do you choose? Periostat, we borrow from our dental colleagues. It's 20 milligrams of doxycycline. It is available as a generic now, so it's cheaper. Aracia is a sustained release one, where it basically gives you 30 instant and then 10 sustained. That one, again, was quite expensive. One of the oculoplastics docs that I co-manage with, he always puts all his patients, or all the patients I refer to him, seem to go on Aracia. He likes that. Question on which is better, the monohydrate or the hyclate. I think a lot of it just has to do with which is cheaper for the patient. Theoretically, the monohydrate's a little bit more bioavailable and less GI upset, but it's sort of academic. I think it's really which one you prefer and which one is available for the patient. Sometimes there have been some availability issues, as I alluded to before, where we couldn't get Doxy or certain forms of it, and I had to go to the minocycline. And cost is all over the place. It used to be one of those $4, Walmart medications where you just go in and it's $4. Sometimes I've seen it for 50 or 100 bucks, and it's Doxy. So things are all over the place, and that's where you may want to have the patient shop around or see if they can use like GoodRx. Obviously, these are all generic, so there's no coupon for it. So you hope that the patient could find it, at a cheaper rate. Because a lot of times these patients are not just going to be on it for a week or two. Most of the time, especially when you're treating eyelid disease, they're going to be on it for many months. So you want to make sure that you get them a 90-day supply and that they're able to get it at a reasonable reasonable cost. I just wanted to point out, this study is a few years old now, but they actually went head-to-head between Doxy and Azithromycin in a double mass clinical trial for treating MGD. So what they did is they put somebody on a Z-Pak for 5 days, and then they also put other patients on the Doxy, for twice over a span of a month. And what they found is that the outcome of the MGD treatment was basically about the same. So, a clinical pearl is that you can give a Z-Pak, which just as effective on a 1 5-day dose versus having to use Doxy. Obviously, the side effect profile of those things we talked about with Doxy is not an issue. So think about that. I have used azithromycin a few times. I haven't been 100% impressed with it. I don't know if any of you guys out there have tried it for MGD, but it is an option, for some patients. So I wanted to just bring that up to you guys to see if you want to try that. The obligatory dental discoloration slide that we always show in an oral meds lecture whenever you're doing something with Doxy. This is kind of what happens to the teeth if you give it to a young child. Let's spend a little bit of time talking about dry eye. There are omega-3s, which is, again, is oral medication. What is the proper dosage? Is it 2,000 milligrams a day, 2,500 milligrams a day? A lot of the stuff is kind of, is definitely questioned, and there's a lot of different back and forth. One of the biggest things to ask is, what's better, ethyl ester versus triglyceride? It depends on what company that you're actually, talking to. The triglyceride theoretically is better than the reesterified version, more bioavailability, more purified, not quite as many side effect profile as far as, GI, the burps and all that. Then there's also another formulation with the GLA, which is Hydro-Eye. I know a lot of our colleagues, definitely go for that. So there's a lot of different controversies within the oral omega-3, market. There's been a question, can you use, omega-3s with blood thinners, and that's mostly been debunked, I believe. There's also something called Krylol. I have some patients that have used that. That is a much lower dosage than some of these other fish oils, but some patients do use that. Just to point out, there are actually two different prescription-based omega-3s that are out there. They're supposed to be prescribed more for patients who have very high triglycerides. Both of these are the ethyl ester version, if that means something to you, and for a lot of docs it does. So basically, you can actually write a prescription for this, I guess, depending on which state you're in, because it's applicable for the eye, and you can use it as a treatment for MGD or dry eye. I could talk a couple of minutes about the DREAM study, which came out a couple of years now. Penny Asbell was the lead author of that, and that also is very challenging. For those of you who don't know, the DREAM study basically showed a fish oil product versus olive oil. And what it showed in the study, what they pointed out is that the placebo, which is the olive oil, basically had the same effectiveness as the omega-3 fish oil. And the study, depending on who you talk to and what you read through, I feel it has some flaws in it because you're using a product that technically does have some anti-inflammatory properties to it. And we know the Mediterranean diet is very good for just overall health. So I think that the design of the study probably wasn't done as well as it could be. And depending on who you talk to, again, some patients, some of our colleagues will have credence to the DREAM study, and some will not. So the other thing about the DREAM study as well is they were able to use other products along with the fish oil or the olive oil. So the study is sort of muddled in that way, and exactly what was going on. They were able to go on and off different things during the time of the study. So I find that the DREAM study is a little questionable in some of the results. That's just my personal opinion. Okay, so we finished with dry eye. Obviously, being in a cornea practice, I prescribe a lot, and we see a lot of patients with herpetic disease. So we'll talk a little about oral antivirals. These all inhibit viral DNA polymerase. They're all well tolerated and safe. The kidney disease is very important. So if they have kidney disease, I just had a patient last month who came in who had a kidney transplant, and she had zoster, referred in by a primary care doc, and I needed to see her. And the question is, what dosage should I put her on for Valtrex? And I actually called a nephrologist, and he got right on the phone with me and was very appreciative. And we titrated the dose down, and she did very well. She did great. He even wanted to see her during the treatment process to do some blood work to make sure that her kidney functions, the BUN and creatinine, were still within normal range. So if they do have kidney disease, I would definitely contact their primary care doctor and nephrologist. So there are 3 different oral antivirals. Now they're all generic. So the acyclovir is probably still the cheapest. I find some insurance plans still want to cover that. These are all category B. All the oral antivirals are. So whenever I talk to audiences, I always just tell them the easiest thing, and students, the easiest thing to do is to try to remember that with oral antivirals, whenever you're doing a dosage, you double the dose for zoster. So if you want to just remember one, I use Valtrex the most. Valtrex, I just double the dose for zoster. Remember what you do for simplex, double the dose for zoster. So the head study, I'm not going to get much into it. It basically shows that if they do have stromal disease, you have to use topical steroids. You could hit it hard with steroids if you want to, and then cover with the topical antivirals or the oral antivirals. And the main part of the head study was just the recurrence rate of the prophylaxis, and basically showed that the oral medication used once a day, like the Valtrex 500 milligrams once a day, or Famvir 250 once a day, prevents recurrence of herpetic disease by 50% in 1 year. So that's pretty significant. And just to let you know, there is going to be a Z study, and I'll talk about that in just a moment. So not Canadian Z, but the Z study, the zoster eye disease study. So we talked about the kidney function. So if they're going to be on it long term, so if I have a patient on a prophylaxis, I'll usually send a note to their primary care doctor, just say, hey, get some blood work. Let's just check their kidney function just to make sure there's no issues. And what's really scary now is that there are some resistant organisms to HSV. So the problem is we only have these few select medications. If there's resistant organisms to herpes simplex, what do we do? And that's a question for infectious disease docs, I guess. And just a little highlight for some people, if you want to know, there are patients that are lactose intolerant, and the valcyclovir or Valtrex is preferred in lactose intolerance. So patient does need to go on oral antivirals. If they're lactose intolerant, valcyclovir is the way to go. So like I said, they're category B. These side effects sometimes are also, that's the trouble with some of these medications. The side effect profile almost mirrors exactly what they're feeling when they have this condition. Let's talk a little bit about topical versus oral antivirals, and I get that question a lot from my students and from colleagues. What should we use, oral? Should we use topical? Should we use both? To be honest with you, nowadays, because of insurance coverage and availability, I can't remember the last time I prescribed the topical antiviral. First of all, the topicals are sometimes hard to obtain. A lot of pharmacies don't actually carry them. The Veroptic has been around for years and years and years. That is 9 times a day. It's very toxic to the cornea, as we know. It's very hard to get a patient to take a drop 9 times a day. It has to be refrigerated by the pharmacy, so that's why a lot of times it's hard to get. Zergan's a great gel. It's not a drop, but it costs sometimes $300, and we don't really get samples of it anymore. So it's very difficult to get. So an oral antiviral, we know the pharmacy has it. You just call it right in, and they're going to pick it up 5 or 10 minutes later. And the the topical antivirals are category C. So again, if they have a pregnant patient, I wouldn't use that. There also the question is, should you use both? And I don't really think it's necessary. Some people have said that if they have a central dendrite, then maybe you should do both. If it was your eye, would you want to do topical and oral? A case could be made for that. But again, I think just doing oral antivirals, assuming there's no contraindications, plus the fact that it's category B, plus it's probably cheaper, and plus it's available in the pharmacy, I typically would just go to oral antivirals right off the way. And the compliance is much better. The Zergan is 5 times a day. Again, an oral antiviral, you're going to take it 3 times a day. It's much easier than, except for the acyclovir, is much easier to get a patient to do, because we know a lot of our patients are not going to be compliant. So this is the dosage. You guys can write this down if you want. Most of you guys probably know this. The acyclovir, of course, is going to be 5 times a day, 400 milligrams. Famvir and Valtrex, 250 for Famvir. The Valtrex is double the Famvir. So for the recurrence, for the head study for prophylaxis, so the acyclovir, usually I have a patient do 400 twice a day, and then the Famvir or the Valtrex once a day. And usually have them do that for a year, or 6 months to a year. So this again is caused by the simplex virus. We all know this stuff. It's activated by UV trauma fever. It's in our bodies. Just about all of us have HSV in us by the time we're an adult. I think it's like over 95%, I think, by the time you're 18, I believe. So with HSV, there's a 10% risk of recurrence after 1 year and 50% after 10 years. So some of the signs and symptoms of HSV are very challenging because it can mimic a lot of other things. It can mimic a foreign body, dry eye, viral conjunctivitis. So we talked about the topical versus oral thing. Let's move on to Zoster. And Zoster, again, is, it's one side of the face. Sometimes can affect the nose and the eye itself. I get a lot of referrals from primary care docs who diagnose patients, and a lot of times they're already on the oral antivirals, but they just want to rule out any ocular complications. So it's caused by the reactivation of chickenpox. We know that. Flu-like symptoms, which can be challenging because, again, it could be a whole bunch of different things. We know that it erupts along cranial nerve number 5. It's an acute vesicular rash, but sometimes the rash part does not show up till later. They'll just get sort of a tingling that they'll feel in a certain dermatome. It does not cross the midline. The board question, what is Hutchinson's side? The tip of the nose, that typically will indicate ocular involvement, although not all the time. As I said, you get tingling, crawling sensation on affected dermatome. So these can cause, the Zoster definitely has more of a dangerous side effect profile for the whole eye itself. I mean, HSV can cause keratouveitis and glaucoma and things. But the zoster can definitely cause more complications typically than the simplex part. So you can get keratitis, edema, anterior uveitis. We know there are things called pseudodendrites, which sometimes can be hard to determine. So 33% of the population will get shingles during their lifetime. So these are some of the things you can see, anything from eyelid edema and vesicles. You got a follicular conjunctivitis. We talked about the pseudodendrites. It can definitely cause inflammation within the eye, uveitis, and then of course some really dangerous things like optic neuritis, UM palsies, and even chorioretinitis. So this is the dosage for the post-herpetic neuralgia. So again, double what we talked about with the simplex, where you're doing 800 milligrams 5 times a day. Valtrex, which is 1,000 milligrams TID, or Famvir 500 TID. We always taught the 72-hour critical period, so you try to get them on that medication as soon as possible. Like I said before, a lot of times I don't even see them. Either their primary care doc or an urgent care doc will think they have shingles or zoster, put them on the antivirals, and then they come into the office for me to check to see if there's anything going ocular-wise. So we talked about the Z study, which is in process right now. What that is going to show us, I believe, is that the same thing with the head study, where you do prophylaxis of antivirals after zoster, that it will reduce the incidence and risk of recurrences. So that should be the recruiting patients. I think it finished recruiting patients, and I think they're going to be, that'll be out in a few years, but it'll pretty much validate what we do already clinically in practice. So just as far as, health, healthcare and public health stuff, there are vaccines for zoster or shingles. The previous one was available. It's called Zostavax, which I believe was now off the market. That was a live attenuated virus, but it definitely did show a 50% lower incidence of zoster and 66% decrease in post-herpetic neuralgia if zoster is acquired post-vaccination. So we don't know how long these vaccines do work, but it has been supplanted by the Shingrix vaccine. And I know some of you guys out there probably have taken it. I have not taken it yet, but I've heard that the first dose isn't so bad, but the second dose is pretty bad. But I think we definitely need to talk to our patients about this. We talk to all of our post-graft patients who've had zoster, that they should get the vaccine. We have them wait usually about 6 to 9 months after their transplant to make sure that everything's okay before we have them do the vaccine if they haven't gotten it. But I think it's important to tell our patients you definitely don't want to have recurrent zoster in a transplant. So this is public health. I think it's a good idea to ask patients if they have taken this or if they would plan on taking it. It's a good idea. For a while there, it was hard to get. I think now you can kind of get it anywhere that you would like. Okay, we're going to finish up with fluoroquinolones, just to sort of circle back to antibiotics. And the reason why I kind of held this for the end is that fluoroquinolones, from an oral medication standpoint, is for me, it would be very, very unusual. I can't remember the last time I prescribed an oral fluoroquinolone. Topical, of course, as we know, we use that all day, every day for our corneal infection patients, pre and post-op cataract and other surgeries. But the oral medications I'll show you is kind of a fairly risky proposition. So all the fluoroquinolones, all the different generations, we know this stuff. It inhibits bacterial DNA synthesis. There's a significant overuse and resistance in medicine. I put a picture of a cow on there because the livestock get fluoroquinolones in their feed, prevent them from getting infection. Obviously, we ingest them, and those resistant organisms now are within us, and that helps to promote the resistant organisms. So medicine, we talked about, sulfa medications for UTIs and fluoroquinolones as well, where they're used extensively for both throat and respiratory infections, and as well as UTIs. So it's not our fault that that these resistant organisms are there. It's just that it's used so much in medicine that there's nothing you can do about it. So just be aware of that. Even when we use topical, you look at the ARMOR study. there's a lot of resistant organisms out there. So with fluoroquinolones, it is category C, just to let you know. It's not category B. So pregnant patients cannot use it. Also be very cautious in patients less than age of 18 because of bone and cartilage formation, and also in the elderly as well, which we'll talk about. Again, no pregnancy and no nursing. If they have kidney disease, it's contraindicated. And the big thing about any of these oral fluoroquinolones is this black box warning. Just to show you what ciprofloxacin from an oral medication standpoint is, the dose is, again, 250, 500, 750, BID category C. The black box warning, I'll show you a slide right after this. Just be cautious if they have myasthenia gravis, you can't give them oral fluoroquinolones. And then just like we talked about before with the azithromycin, same thing with cardiac arrhythmias with the fluoroquinolones orally, prolonged QT interval time. So this can cause cardiac arrhythmias, which can be fatal. So if anybody has the history of cardiac arrhythmias, I would not prescribe oral fluoroquinolones. So this is the black box warning for Levaquin. It just basically says increased risk of tendinitis and tendon rupture in all ages, further increase in older patients over 60, and patients taking corticosteroid drugs and kidney, heart, lung transplants. Like I said before, also, you cannot give that to a patient who is under the age of 18 because of their cartilage and bone. So the big thing with the oral fluoroquinolones is this, which is Achilles tendon rupture. And the thing about oral fluoroquinolones is you can give a patient oral fluoroquinolones, and then even years later, they can develop, let's say, an Achilles tendon rupture, even though they have not taken the medication for many years. So just, again, trying to talk you guys out of prescribing it if you don't have to. There are a lot of these side effects, and if there are better medications to use or more appropriate medications, try to use that. If they're, obviously down to fluoroquinolones and you don't have any of the other categories that we discussed, you have to do it, but try not to. And I will say that all this is only applicable to the oral medication version, not the topical. We use topicals all the time. We don't run into these issues. It's not systemically absorbed like it is from an oral standpoint. This I took off of the internet. It's just from a lawyer's page. So they're obviously very cognizant about side effects of these medications. So they basically, they're ready to, to take on these cases. There's reports, because again, with using fluoroquinolones, it affects the connective tissue. Our UMs are obviously connective tissue. So there's some reports of diplopia being induced by fluoroquinolones. So hopefully by now you guys can tell that I'm not a big fan of oral fluoroquinolones for eye care for sure. And also RDs, there's been some reports, yes and no, that do they cause retinal detachment. There was actually one study, which I didn't put on here, but actually we're talking about even topical fluoroquinolones possibly increasing risk of RDs, but that was refuted. So just be aware that retinal detachment is a possibility with oral fluoroquinolones. And that is my lecture. We are done. There's my email down at the bottom. I appreciate everybody's attention. And oral medications, I think, are very important in eye care. We use them for many different purposes. Just be very comfortable with certain medications, and I hope the ones that I pointed out to you are ones that you guys will be comfortable using. But again, there's my email. If you have any questions regarding this topic or cornea, contact lenses, I'd be happy to discuss that with you. And again, thank you for your attention, everybody. Have a great Labor Day weekend. Be safe.
Great. Thanks, Dr. Sorkin. We still do have about 20 minutes left for the CE component. So if you're listening in and you have questions, please put them in the chat box or the Q&A now, and we will get to as many of them as possible for the next 19 minutes. Okay, so first question from Dr. Gallup. Dr. Sorkin, you mentioned contributing to resistance as a consideration in prescribing oral antibiotics. Do you think there is much risk of topicals doing that? I have heard that since we get such a good kill topically, we probably don't. Any comments?
Yeah, so that's a good point. As long as you're using the medication appropriately for what you need it for, it's very low risk of the topical medication causing resistance. I think eye care was such a small component of the overall medical community that we don't really contribute to that at all. I alluded to like the last couple of minutes that there's a study that they keep on doing, continuing study called the ARMOR study, ARMOR study. You can Google that or look it up, and they periodically put these organisms through multiple antibiotics, and they'll tell you from topical medications and oral medications which, how the resistance is going. So if you're interested in looking into that, that's a really helpful resource for you.
Is that something that's ongoing, or is that just that?
Yeah,
okay.
they continue to produce new versions of it periodically. Yep, they've been doing it for a while.
That's really helpful. I don't think I ever learned about that, but I do think that a lot of doctors that are prescribing these medicines, it would be good to just have that as a resource to kind of look up every now and then, like you said, just to see kind of where's everything headed. So that's great. Next question from Dr. Brill. Please discuss the possibilities of patients getting floxed. I'm
sorry, I'm not familiar what he's asking there.
I think he's talking about maybe fluoroquinolones. I don't know, Ray. You can put your comments in. I can certainly I can verify that.
I'm not sure.
In a second. Okay, another question from Dr. Gallup. Is there any risk of Stevens-Johnson in topical polytrim?
So yeah, that's a great question. There's a thought that there's a sulfa moiety that's in polytrim, but it's not sulfa based. So it's not contributing to that. That's an interesting question. I've looked into that myself. So there's no risk of Stevens-Johnson with polytrim. Well, I wouldn't say there's no risk. I'm saying there's no sulfa that could cause Stevens-Johnson. I hope that was clear.
Great. Next question is, docs, how are you handling using long periods of antibiotic for dry eyes and increase in yeast infections?
Okay. So, I mean, the only medication you're going to use long-term typically for dry eye is for MGD would be, Doxy. So, yeah, yeast infection. So if your state allows it, you can prescribe diflucan, or it's over the counter or prescription, depending on your state laws. Or again, you can do probiotics and yogurt. Patient can take that with any oral antibiotic, but specifically on a long-term medication, yes, that is a risk.
Yeah, and I remember there were some other doctors that were talking about, there's so many availabilities now with probiotic supplements. They come in liquid form, they come in capsule form, they come in all different things. Yeah, like you said, yogurt, they've got those little shots that you can get at the grocery store. They're just like really tiny ones you can just like drink if you hate yogurt. So I feel like there's a lot of probiotics, and that's kind of like where the culture is heading. And so that's great that we have those.
Yeah. And taking a lot of the antibiotics, if it's appropriate, you can take it with food too, which helps the absorption part.
Great. From Dr. Pohl, suggestions to decrease the fish taste burp after taking fish oil supplements. A pharmacist recommended freezing it, which seems severe. Would keeping it in the fridge help without causing any problems?
So that goes back to the ethyl ester versus the triglyceride version. The triglyceride version for sure has a much less likelihood of having that, the burpees from fish oil. So I think the preparation and the type of fish oil that you're using, I think, is important. There are liquid versions which may be beneficial, like that you can take with food. And I always tell my patients with taking omega-3s that they should take it with food as well. Freezing it, that's not a bad idea, or putting it in the fridge or something. Maybe that'll be a little more comfortable for the patient. But I think the preparation, when you're looking at some of the lower quality versions that you get in certain stores, they're going to have a lot of other stuff in there. So the triglyceride that has just about all DHA and EPA that's going to have a much less risk of a side effect profile with that type of GI upset stuff.
Yeah, that's all great advice. And I remember that there are some fish oils that they have the term enteric coated, meaning that it helps so that you don't have those fish burps. It helps to like go through the stomach first, something like that. And I've tried those myself and they did work. So that's something to possibly try as well.
Yeah.
Okay, from Dr. Sakihara, is there anything you can advise for us on any COVID-related eye conjunctivitis done via telemedicine that would be most appropriate?
I tried telemedicine a little bit early on. I wasn't a big fan myself. The only thing I think really you can diagnose via telemedicine is probably some lid things, maybe like hordeola. And Stephanie, you wanted me to talk about hordeola. I remember you mentioned that to me earlier. So I just wanted, I should have talked about that during the talk, but there's definitely a difference between internal and external hordeola, and I think the treatment and chalasia. So just to let you know, an external hordeola is basically limited to the lash follicle itself. So that is definitely more of an external infection. So those can be treated with topicals like Tobradex or Maxitrol. Definitely hot compresses. And those usually will just come to a head and burst on their own. An internal hordeola is internal. It's actually in the meibomian gland. So anybody who says you should be using Tobradex or topicals for internal hordeola, it's not going to really work because it's internal. It's not going to get, the lid is pretty thick. It's not going to get through. So that is where you want to use your oral antibiotics that we talked about, whether it be Doxy or Keflex or, Augmentin, Z-Pak. So that's where an internal hordeola is actually an active infection in the meibomian gland. If the infection resolves and there's still autoimmune stuff that's sort of left behind, and you get that hard nodule, which is a chalasia, again, topical stuff is not going to dent that. That's where you want to go to your oral medications like Doxy on a long-term basis, fish oil, you want to do hot compresses, and then you want to do your lid treatments like Lipoflow and IPL and all that other stuff. That's not the crux of this lecture, but I did want to distinguish that because I think a lot of people don't know the difference between external and internal hordeola. So hopefully that cleared it up.
No, that's great. I think that gets confused a lot. And that's why I wanted you to just touch on it, just because I feel like that's always a conversation I see floating around on social media. And then I feel like a lot of people are giving other people not the best advice. So just to hear from someone like you that's an expert in this is
I gave, after we talked about that, I asked my extern and she got the answer right. So I guess I'm doing something right.
Oh, good.
She got it right.
Oh, so Dr. Brill said getting floxed from fluoroquinolone is a systemic condition of toxicity of Cipro involving extreme fatigue and heart, kidney, and liver damage, especially mitochondrial damage. It is a known cause for disability.
Oh, okay. Yeah, I mean, as I said, oral fluoroquinolones are kind of nasty. So I agree with you 100% on
that. From Dr. Abu Mali, contraindications between Famvir and Coumadin. I think one of the slides said that there was a contraindication between acyclovir and Coumadin.
It's all in the same class. Yeah, all the oral antivirals are in the same class. But I'll correct my slide for next time. Thank you.
This is an interesting question from Dr. Combs. Have you seen depression or the blues when people are taking oral antivirals?
There's been reports of it. Definitely one of those side effects. I have not seen it personally. I would say that, a lot of patients, especially if they have zoster and they have the postherpetic neuralgia, they can definitely be depressed because it's a long-term situation. A lot of these patients, I didn't talk about it, but a lot of these patients need to be managed by pain management docs and go on, heavy duty, pain meds. So yeah, I mean, I don't know if it's actual impact from the medication or more just the actual condition itself, but these medications can definitely do things like that for sure. Good point.
Great. From Dr. Ung, what omega-3 fatty acids do you recommend for vegans and how many milligrams?
Yeah, so there are definitely a lot of the big companies have products that are vegan versions. I'm trying to remember off the top of the head. I think PRN does and Nordic Naturals does. Those are the companies that I like because they do have the triglyceride version. So they should have the same formulation. I think the big issue with the vegan also is just the gelatin as well. So you have to look at the different formulations. A lot of different companies, I've done research for certain patients that have asked me. I just can't remember off the top of my head. But I know some of the bigger fish oil companies do offer a vegan option.
Mm-hmm. Yeah, and that's a good point, because a lot of times the flaxseed oil, you think, oh, great, okay, this is wonderful, but the actual capsule is made out of gelatin, which a lot of vegans, you know, they don't want to have that, so they have to look for alternatives. So that's a good
and flax really is not as bioavailable, let's say, and doesn't have as much of the good stuff, let's say, as fish oil does.
Yeah. From Dr. Nguyen, for a chalazion, how long would you put a patient on doxycycline?
Yeah, it's funny, when I get to a patient at the chalazion stage, I say, I'm going to put you on doxy for 2 or 3 months. I usually give them about a 50-50 chance that it'll actually work. I said, if it doesn't work, then we have to look either to send you to oculoplastics and have it removed, or sometimes think about doing lid procedures or other lid procedures other than that. So I give them the 50-50. I said, look, if you want to even make an appointment with the oculoplastic for a couple of months down the line, because it's sometimes hard to get into them, just do that. And if it gets better, then you can cancel the appointment. That's kind of how I tell them that. So I'd say give them 2-3 months max. And, you know, obviously you have to do the hot compresses and all that as well. But it's sort of I'd say it's probably a 50-50 shot. Yeah,
I agree. I haven't seen very much success with that when it's gotten to that point. It's like, you're probably going to need some other treatment option.
And it's funny because one of the oculoplastics docs I sometimes refer to, I refer him to the patient. He said, oh, just take the doxy for another 2 or 3 months. And I'm thinking to myself, I refer the patient to you for surgery and you want to put him on doxy, give him more time. It doesn't make sense to me. But anyway, that's what happens sometimes.
Question from Dr. Rebuck. Do you prescribe Ultram, and can it be prescribed without a DEA number? I thought it could be prescribed in the past without a DEA number.
Yes, I did mention that during my lecture. So yeah, Ultram used to be non-scheduled substance, and it was reclassified, I should say, as Schedule 4. So you do need a DEA number in 2021 to prescribe that.
Got it. Dr. Alavi, Levaquin and Cipro are common antibiotics prescribed by urologists. Mm-hmm. How concerned should we be to encounter RD in our patients?
So, like I said in the lecture, I think that there's some debate whether or not that's true or not, depending on which study. There's some studies that say yes, some studies that say no. I think the jury is still out on that. But you know, if you find out that they've taken the medication and they get an RD, I don't know if it's causative or not. It's hard. It'll be hard to tell. But it's a question I don't think that we can answer at this time.
Great. Dr. McRoberts, what oral to give in an open globe in a remote before transfer once the globe is closed? Do we use fluoroquinolones?
For oral medication, I would probably still use, I would use probably a cephalosporin or a penicillin.
Okay.
And we don't have
next,
too many of those in our office.
Yeah, I know, right? Next question. If a patient has chlamydia conjunctivitis and I RX azithromycin 1 gram, how soon should I expect to see improvement in their signs and symptoms?
Well, you're also going to prescribe topical meds as well. It depends on how long they've had it. And the problem with chlamydia is they've usually been treated before and topically with other stuff, or they've had it for multiple weeks at that point. Usually by the time they see you, they may have seen 2 or 3 other eye doctors. They prescribe, Polytrim or Cipro drops or something. So it's challenging to do that. I mean, you'd probably say at least a week or so, maybe 2 weeks before you'd see improvement, depending on how severe it is.
Okay. Is it safe to prescribe topical fluoroquinolones such as moxifloxacin in patients younger than 18 years old?
For sure. Yep. I think Moxie is 2 and over. So yeah, for sure. all the fluoroquinolones. For topical, sure.
Can you comment more on the risk of cancer in men versus women with different types and sources of fish oil?
That's another thing that's kind of controversial. That, you know, sort of like the bleeding, just, you know, the bleeding part with blood thinners. I don't think there's a full consensus on that. I think a lot of that stuff has been refuted as far as cancer risk for men. I think that actually may apply more for flaxseed oil than it does for omega-3 fish oil.
Great. From Dr. Windsor, do you have any preference with treatment for effective lid hygiene, tea tree oil?
That's a whole lecture in itself.
Mm-hmm.
I know, Stephanie, you can promote your lids, you know, lecture.
Yeah, all about eyelids.
Yeah, I think you should promote that a little bit.
Yeah,
yeah, I mean, that's a whole lecture in itself. You know, there's a lot of different decision-making processes that go into that. It's probably a little bit long for us to go over at this time. I'm sorry, but you know, there's definitely multiple ways to treat eyelid disease for sure.
Question from Dr. Frimtiz. Sorry if I mispronounced that. Have you ever used Azocyte once daily for 30 days to treat MGD?
Yeah, good question. So we talked about the oral azithromycin. Azocyte, as you know, is a topical version of that. I've you know, definitely used it on many patients along the way. It's actually a very thick drop, so you can put it on your finger and just sort of rub it on the lid as a topical. It's been hard to get in certain ways. I think a few different companies now have kind of passed it along. So if you can get it and it's not too expensive, then it's not a bad idea. It was kind of reborn. It really didn't work great as an antibiotic, so they kind of reconfigured it as sort of an MGD off-label use. But yes, I've used that many times for MGD topically. Great.
And I remember when it first came out and they came with like those little applicators that was like, remember those? And then like, I don't know, I think that only was like short-lived, but
yeah, they just basically realized that, you know, it wasn't doing well for what they thought it was going to do, so they repurposed it.
Yeah, no, that makes sense. From Dr. Thomas, what is your go-to treatment for internal hordeolum for a pediatric patient?
Augmentin. Yeah.
From Dr. Abumali, how would you treat active zoster patient that's also on Coumadin?
So depending on who they're being managed by, you may want to just run it by their, you know, primary care doc or whoever's, you know, cardiologist, whoever's treating them, just to be on the safe side. You may want to titrate the dose, but usually it shouldn't be a big issue because they're only going to be on it typically for 7 to 10 days.
From Dr. Doe, for an oral antiviral, is it only beneficial to prevent recurrence in herpes simplex and not herpes zoster? Is that correct?
No. Well, so the Z study will definitely show us, I think, that prophylaxis will be beneficial in both in zoster and what we already do with simplex.
Great. From Dr. Gallup, how much does oral like Z-Pak actually reduce the time for resolution of external hordeolum versus no treatment?
For an external hordeolum, so I think for an external hordeolum, you probably don't need orals, at least oral antibiotic. I think topicals work better for the external hordeolum. Just we kind of touched on that a few minutes ago. You can give an oral antibiotic. I don't think it's necessary, but lid hygiene, hot compresses, you know, antibiotic steroid ointment or drops is the way to go for an external. Those usually self-resolve. Those usually don't, you know, drag on and become anything worse, usually.
Great. 2 more questions. Dr. Barton asks, would you prescribe an oral antiviral for a patient with a history of herpes simplex virus prior to cataract surgery to reduce recurrence?
Cataract surgery doesn't typically induce the expression of herpes simplex. I think that it wouldn't hurt. I don't know if it's really necessary per se.
And last question from Dr. Buck. This is an important question. Are there any Seinfeld references specifically about the eyes or optometry, like how Friends did an NCT sketch?
Yeah, there was actually a couple of, well, one where George got glasses, if I remember correctly.
Yes.
There's
Okay.
also one where Jerry was wearing the very thick high plus lenses and he couldn't see anything. So I think there was probably at least 2 episodes of Seinfeld that did have that. And that was probably the toughest question out of all of them.
Yeah. Well, thank you, Dr. Sorkin. That was an amazing presentation. Tons of great comments and feedback already. We can't thank you enough for donating your time and your knowledge to Woo U. And thanks so much again for everything.
Thanks so much, everybody. Take care.